area, okay, by taking our syringe, an empty syringe, and attaching this, and then pulling back. And we should, if we're in the stomach, get what? Some type of stomach contents, okay? We could take a little bit of that onto a pH strip and see if it's acidic versus basic. If it's super acidic, guess where we're at? We still don't know. We more than likely are in the stomach, but we could, if they've aspirated, they might have stomach contents in their lungs. So the only way to 100% confirm that they are in the stomach is with an x-ray, okay? So if I've pulled this back and I've checked it, I'm like, okay, I know I'm in, at least I'm in the stomach. They're not coughing, okay? They're not appearing, I mean, they might be gagging a little bit because they've got that thing in the back of their throat. So I will take this, clamp it off, tape this to however my facility prefers. Now, some places will have these lovely little...
All done on my job.
So hard to find good help these days.
I'm telling you. Got enough coffee this morning, I'm very sorry.
So this is a nice little strip to utilize in that it's got a nice little Velcro type thing here that goes across just like this and tapes down, and then this little Velcro thing holds that in place. Very nice. Okay.
But we're not going to have you stick these to the
mannequin.
mannequin.
No, because we're not supposed to use any type of tape. But it's got this nice little bit of sponge here to kind of buffer, so that way you don't get pressure sores around the nose or on the lip. Because if you go old school, because your facility's super cheap and doesn't think that, you know, this is a necessity for your patients, and you have to do old school tape with a chevron, okay, like this. If you tie this too tight up against the nair like that, you're going to cause breakdown on that nair, because again, it's still pressure, okay, up against their skin. So with a chevron, get like a nice piece of tape, and you don't want it to be too long. You want about from the nose to the chin in a length, okay? Because what you're going to do is you're going to take that one strip and tear it down the middle as carefully as you can. Now this is paper tape, not the most ideal tape for this, but it's what we have.
Our patient can tolerate.
Yes. They make silk tape, which is a lot better. It's a lot stronger. And then they have plastic tape, which or Metapore tape, which has little dots in it that are easy to tear. Okay. They all have different properties and stuff. You will get familiar with those as you go along. But I'm going to take my chevron here, and actually before I even get there, I'm going to take the ends of the pants that I've created and cuff them, so that way it's easy to find the end, so that way when we are taking this off, we don't have to sit there and try to peel it off that way. But I'm going to take this, I'm going to angle it across the nose towards my NG tube. I'm going to take one and just wrap it around in a spiral down the NG. I don't want to go over the same area, because then that's just going to cause more problems later when I go to take it off. And I'm going to take the other side and go around the other direction around that top one. Okay, and now it's less likely for them to be able to pull it out. Would they be able to pull it out?
Yes.
You betcha. Okay. Now we have a couple different types of NG tubes that you will possibly run into. These are the most common. These are short term, okay? And they are made of plastic, but if you look on here, there's a white line all the way down it that is radio opaque. You can see that on the x-ray. Otherwise you wouldn't be able to see this at all, okay? The other type of tube that you might run into is called a Dobhoff tube or a Corpak. They're very similar. They're for a longer term use. They're more comfortable because they're softer plastic. Those typically have a guide wire in them that helps you with placing it, and then once you know that it's in the right place, you can take that guide wire out. All right.
And please do, because I've found patients with the wire still in.
And feeding going through.
Yeah. So
Now, that still is a short term, but it's a little bit longer than this. If someone needs tube feedings or anything like that long term, they typically have one surgically implanted. called a pec tube. It goes right from the outside of the abdomen directly into the stomach. Okay. It has a retention balloon, and that one's usually sutured in place.
One other thing, you might get some of these patients back, and this blue part has been cut off. This is a no-no, because this is your vent part.
It's your patient safety.
It's your patient safety, okay? If that happens, you have to let the physician know, and then another tube has to be placed, because this is the safety part of this. It vents the air out of the belly. There's no purpose when it's cut off.
Or the other thing I've seen is they'll do this, which I'd prefer them to do this because then I can always
Exactly.
fix it.
Okay, Hercules.
Come on, right?
And that happens too. Someone has crammed it in there so strongly that they can't get it out.
Son of a biscuit, man. There we go.
They tied in a big pretty bow knot.
Why?
Exactly. So you want to be very aware of what your tubing looks like
And what it's for.
and what it's for. You want to make sure all the pieces are there. Okay?
Alright, so now we've gotten this placed, we got x-ray confirmation, we can hook up the tube feedings to this, or if we're using it for GI compression or decompression of the stomach, we can hook it up to suction and pull all that extra stuff out of their stomach without them having to.
And you know what I've also noticed is that they take this and they'll hook
Oh.
it up to here.
Yeah, no.
Is that going to help anybody? No.
No.
So
It
make
needs to go
sure
here.
you have saved your little plastic piece. If not, then you have to become MacGyver and figure out other ways.
Or open up a whole new packet just to get this one
And
piece,
just get that one piece.
which costs a lot of money.
It does.
Now, let's say it has been a week, we've gone on to, we've done our 3, we come back a week later to do our next 3, and we get the same patient, and now the doctor says, okay, we can go ahead and take the NG tube out, okay? That's the easiest part of this whole
Yes.
thing, because all you need is the doctor's order. You don't have to worry about any type of verification type of a thing with an x-ray or anything like that. But you do want to make sure that you have, of course, still your piston syringe and something, both for insertion and removal. You want to have something across their chest, because if they do throw up while you're trying to put it in, at least you don't have to change the entire bed. Okay, you have this to change. When we're taking this out, okay, we want to make sure that we flush it before, because even though it's
Bye.
in their stomach and everything, there could still be like food and gastric juices inside the end of this, and so we want to kind of like pack it with water essentially, so that way we know that none of that's going to be coming out and possibly going to their lungs as we're taking it out. Does that make sense? So I'm going to flush it with at least an ounce of water, which is how many milliliters? 30 at least, which is about half of this syringe. That's 30 milliliters. Okay. Now I have it in water for right now. Take this off. Of course, I'm going to be wearing what?
Gloves.
Gloves. I'm going to flush first. Let them know they might feel a little bit of pressure or a little bit of temperature change in the back of their throat. Okay. Get it all nice and flushed. I'm going to keep this on, because if I take this off, now it can put it down like this, it can cause a siphon and suck things out on its own. Okay. Have you guys ever cleaned a fish tank with the vacuum thing that takes the water out? Basically the same principle here. Okay. So I'm going to now take my tape off of my patient's nose, having explained to them we're going to take this out. I want them to take a nice big deep breath, and on 3, I want them to be breathing out as I am withdrawing this. Again, it's just another fail safe, because if they're breathing out and there's anything on the end of this tube, whatever's on there is going to come out as well. It's not going to run down their lungs. Okay, so I'm going to say on 3, 1, 2, big breath, out on 3, and just take it out in one swift movement. It's going to feel like the world's longest booger.
Yes.
Okay, let them know that. Little kids will be like, cool! Okay. But, and then I'm going to check to make sure that this whole tip is intact. because it's plastic. It's, you know, it's not necessarily the greatest organic components, but it is still able to be broken down by the gastric juices within the stomach. Okay, so this can deteriorate over time, and I want to make sure that I'm getting all the pieces out. If not, I would document it and let the physician know. Okay, it might be, you know, no big deal. They could just pass it on their own, but depending on what's going on with the patient, it could cause complications down the road. Okay, if they have diverticulitis, which is the infection of the little outpouching of the intestines. This can cause them a lot of pain and a lot of issues. Even in somebody that doesn't have that, it could get into their appendix and cause the inflammation and everything, and have them have to have an appendectomy. So be aware of that. All right. Then I'm going to wrap this up here, and I'm going to take it and throw it, not in the linens, but in the biohazard bin or in the trash can at least. Okay. And then that's done. I'm gonna come over to my patient, provide some oral care, because they're probably gonna have a very dry mouth, and just get them going that way.
Because
Okay.
9 times out of 10 what they'll do is they'll have the patient eat one meal and wait a few hours to make sure,
It stays down.
and it's probably a soft mechanical diet, like scrambled eggs or something of that nature, to make sure it stays and doesn't come back. And then you might pull out something from their stomach at the same time. So that's why you flush it, to make sure everything stays where it's supposed to. Okay.
And also too, if we give medications down this tube and they're hooked up to suction, please make
Always
sure
happens.
that you hold the suction for a good 30 to 45 minutes. Because if you put the medications down in there and then you hook it right back up to suction, what do you think is going to happen? The medication is going to come right out. So you got to hold it for 30 to 45 minutes just to allow the body to break it down and absorb it, and then we can hook them back up. Okay? If they're not able to tolerate it that long, then we probably might want to see about making everything IV. Okay?
If
But
possible.
we want to be able to utilize the stomach as much as possible, because, again, that basic principle, if you don't use it, you lose it. And getting, or having a patient develop what's called an ileus,
It's not
where the
pretty.
stomach, instead of it continually moving like it's supposed to, it stops. It's very hard to get it going again.
Mhm.
Okay, it's not like the heart where they can literally just touch it and it starts going again when they do a transplant. It takes a lot of effort for these patients, and it's not very comfortable.
Right.
So, all right. Any questions?
Questions,
Well, the
concerns?
water, does it have to be like room temperature? Cold?
No, you don't want it to be hot, but cool would be fine too. Sometimes if you're having if you're wanting to stiffen up your tube, for instance, when you're getting ready to place it, like maybe you've tried a couple times and it's just not wanting to go down or anything like that the way it's supposed to, we typically will put it in ice water,
Yeah.
to make it a little bit harder or stiffer to get it to go where we want it to go. So
And it
that's
works
one
really
aspect.
well.
Yeah, it does. So I would say, you know, at least room temperature, but definitely not hot.
Exactly.
Now, can somebody swallow with this?
Yes.
Yeah, they can swallow around it. They can take pills, you know, just unless they are ordered NPO. Okay. A lot of times nurses will think, oh, they've got an NG tube, they can't swallow. No, unless they're ordered NPO, they can still swallow around this.
So how often are you going to check the placement of your tube?
Every 8 hours? I don't know.
Every time you access it, you want to make sure that it's in the right place. Because on here, you've got several different openings for like that first 3 or 4 inches on every single type of NG tube like this. And if this comes up and is leaking, because there 1 or 2 of these is above the cardiac sphincter at the top of the stomach, that can build up and then fill over into the lungs.
And it'll cause GERD, which is another thing you'll learn
Yeah.
soon.
Yeah, we talked about that yesterday.
Severe heartburn.
Oof.
That is the worst thing you ever want to have. And then they got to do a whole bunch of other tests, but
Yeah, I know.
ask Mr. Chris. And then when you come in there and you find your patient Patients just don't lay perfect like this man all the time, every time.
Thank you for your participation.
You know, and you've got this in, and it's pinned to their pajamas, not their pillow, not their blanket, pinned to their pajamas, their gown. And you come in, and this piece of tape's way down here. Where do you think this tube's sitting? Back of their throat. So you always want to make sure. If it's 24 hours old, you can push it back in. Now, if this has been in for a week, I'm taking it out. Okay? Then you're going to put it in a new one. Okay?
Well, or call the doctor and see if they want to put
Yeah,
it.
after, and that was my next statement.
Yeah.
If it's been in for a week, patient's been tolerating things, give the doctor a call. Patient's been, you know, taking his pills by mouth, not an issue, not a problem, not getting much out of the NG. Can we leave it out? And he'll probably give you a, you know, soft mechanical diet to try, see how he does. If your patient's still throwing up, even though you got the NG, have him to put it back in. Okay? So you have to use your critical thinking skills at that point, okay? But if it's, he accidentally pulled it out without realizing it, and it's only been 24 hours, use the same tube. And then what are you gonna do once you get your tube in? X-ray, that's right. What kind of X-ray are you gonna get? Chest is only gonna come to here.
KUB.
KUB. Kidneys, ureter, and bladder. We're gonna take up this part of it. Okay? I'm shorter than you. So, yes. Catch everything?
If you're gonna transfer your patient from one surface to the other, like we learned last week, make sure you've disconnected this, even if it's pinned to their patient gown, make sure you've disconnected this from the suction. I literally had a nurse that I was working with, I was a tech at the time, I was helping to just transfer, she wanted to do the transfer. And so I was just like holding the bedside commode in place for the patient to go to. And she thought, oh, well, it's pinned here. The gown went off as she moved.
No.
Because this line wasn't long enough to reach, and so then it started taking out the NG too.
Oh dear.
That was placed by the surgeon. So really bad.
So yeah, you gotta make sure if it's placed by a surgeon or a doctor, you wanna make sure that son of a gun doesn't come out.
It does not move.
It does not move. What? Because if they gotta come down and take care of it, you're just standing there going, it's this, Irene.
Yes. Let's see. Anything else?
I think we got it.
Okay. I do have a couple more handouts for you guys regarding nutrition and some NG stuff, but I want you guys to go ahead and take a 10-minute break. I'm gonna set up a couple more stations for you guys to practice with in teams, and